Good afternoon and thank you for having me. I realised from the show of hands before that most of you are actually parents of someone with a Fontan circulation, and so the concept of pregnancy may be a long way away for a lot of you, but hopefully will hold some interest nonetheless. And that's really my non-traditional disclosure slide. I don't really have any disclosures, but I do want to tell you that the way I approach pregnancy has undoubtedly been influenced by my own experiences as a mother, and the older I get and the more pleasure I derive from my children, I come to appreciate more and more how important this is for everybody. So why are we chatting about this? There's quite a large body of work about the relationship between heart conditions and pregnancy, but also we're talking about people with normal hearts having issues in pregnancy. So heart conditions remain the main cause of maternal mortality, so maternal death during pregnancy in the developed world. And then there's some conditions that emerge for the first time in pregnancy that affect the heart, such as peripartum cardiomyopathy, or what we would use in our non-PC language to be heart failure. And then we think about our congenital heart disease patients, where there's certainly data about them having issues in pregnancy, and then if you'd like, we can hone down into those women who have a Fontan circulation. And it's something that there has been a growing body of work around. We know that pregnancy, even in normal hearts, is a time when women can have more arrhythmias. I've mentioned to you about the fact of heart failure, but particularly for women who enter pregnancy with a pre-existing cardiac condition, one of the questions that we still have is whether there's the possibility that the pregnancy might actually add to some deleterious effect, possibly many years down the track. In terms of the effects on the pregnancy itself, we know that women with significant heart disease have got increased miscarriage rates and tend to have smaller babies that come early. And there's also potential side effects along the way that we need to consider for the baby, particularly if mum needs to be on any medications. So I'm very conscious that I can't stand up here and give you specific advice to all of you. That would be an impossible task. So I really do just want to talk in very general terms about how your cardiologist will hopefully approach the discussion of pregnancy, whether that be for yourself or for your child down the track. And really the things that I want to try and draw out are very general, not really specific. So the most important thing, if you can, is not to turn up to your cardiologist for your annual review saying, guess what, I'm pregnant, but try and have that be a conversation that has been some time in coming. And I personally ask all our new patients who come across from the Royal Children's at their first visit what they've been told about pregnancy, whether they believe pregnancy is possible down the track, and what their thoughts are about contraception. Are they using any? Is it a discussion they've had? I think these are all discussions that are really worth having in anticipation. So broadly, contraception, whether pregnancy might be possible, whether there might be some issues around your health that need to be addressed beforehand, and really this concept that it becomes something that you plan for. What we try and do is have all our ladies with congenital heart disease also seen by a high-risk obstetrician, and as mentioned, we do run a cardiac pregnancy clinic where during pregnancy we see women both with a cardiologist and an obstetrician, and I think that's really important. So very broadly, the guidelines talk about pregnancy in the Fontan circulation as being World Health Organization risk class 3, so that's defined as being a significantly increased risk of maternal mortality or morbidity, and so as a group we think that these are moderate to high risk pregnancies, but I want to delve a little bit more into that as the talk goes on. In terms of assessment, it really won't look very different to what you or your child is already going through during their regular reviews. It would be taking a history, doing an examination, an ECG, saturations, some form of imaging, which usually our workhorse, if you like, is the echocardiogram. But I think very importantly, having an up-to-date exercise test and seeing how well you or your child can exercise before you get pregnant. Because pregnancy, if you like, is, I think, the ultimate stress test for your heart. It does put a significant physiological load on your heart, and if you do really well on a stress test, that gives us much more confidence about how you'll get through pregnancy. There may be some other tests required depending on anything else that's come up along the way, such as a Holter, maybe more advanced imaging, maybe even a catheterisation. Why we do this is that although those guidelines exist, it's really impossible to come up with advice that fits everyone. So yes, that's what the guidelines say, but I think the challenge for us as doctors is to try and individualise that to you. And so we really want to give you the best information we can about your risk in pregnancy. So again, speaking very broadly, what are the challenges? We know there are significant challenges for women with a Fontan circulation in terms of getting pregnant. They seem to have lower ovulation rates and achieve pregnancy less often. Staying pregnant is difficult. There are higher miscarriage rates. Staying well, you will need more reviews during pregnancy than other women going through pregnancy. Your baby may well have more screening through pregnancy to look at how they're growing. Managing labour, so we actually sit down with around our really complex patients, we'll sit down with the obstetrician, with an anaesthetist, if need be with a neonatologist, whoever else we need, midwives, cardiology nurses, and make a plan about delivery, how to manage the delivery, managing postpartum complications. There's been some new data in the last couple of years about bleeding being much more common in congenital heart disease women, and in particular within that group, in the Fontan circulation group. And we always need to think about the possibility that your baby might come out needing help itself. So again, where you deliver is going to be relevant. I have put in, on purpose, in much smaller writing, the possibility of having a baby with a congenital heart defect, because that's certainly not something that we see as being anywhere near a yes-no. It's a much smaller risk. It depends on your original morphology, but for most people it probably increases from about 1 in 100 to somewhere around the 5 to 7%, so 5 to 7 in 100, so not an enormous risk. So is pregnancy possible? And I think the answer is yes, but not for all women with a Fontan circulation, and in some respects that is also what we find in other people in our environment. There are a lot of people out there with other health conditions or infertility who also are unable to have a pregnancy. In terms of what's published, what maternal health issues are described in the literature, I think that's now a really consistent story. So just remembering back to the WHO discussion, conclusion that there was an increased risk of maternal mortality and morbidity. So the morbidity data is really very consistent. Increased atrial arrhythmias, heart failure, deterioration in functional capacity and bleeding. But I think really importantly, when we've looked at all those published series, none of them have reported a maternal death in pregnancy. Now there is the possibility that someone has had a bad outcome and that hasn't been published, and partly that's why it's so important to be part of the registry and have your story included in what we know, because it influences what we tell women down the track. But it's also important because it just does raise a question about whether that statement, in terms of the degree of concern around pregnancy, is actually written right. So I want to tell you a little bit about some of the pregnancy research that's come out of the ANZ Fontan Registry. And when I spoke at the first education day 4 years ago, I had some very preliminary data on that paper that's now been published last year, that looked at fertility and pregnancy in the Fontan population. So if you took part in that, thank you. We had questionnaires that went out to all women with a Fontan circulation aged greater than 18. We had a fantastic response rate back in terms of just collecting data about the onset of puberty, contraception, what advice you'd been given about pregnancy, and then had sort of diminishing, if you like, success in getting women to share if they'd had a pregnancy, to share what their experience had been. And I think partly that's because it has, for some women, as I said at the start, been a very difficult road. What the registry is doing at the moment is participating in a study called PROFAT, which is Pregnancy Outcomes in Fontan with Anticoagulation Therapy. It's been run out of the United States. There are 27 different contributing sites around the world, although they've not all commenced putting in data. And I do want to thank Janina, who has spent hours with me going through the registry information and filling in these very long data entry documents for this study. And that's really looking at how women are managed with anticoagulation throughout their pregnancy and what sorts of issues they're having with respect to both thrombosis and bleeding. And will hopefully give us some really important information about how best to manage women with respect to anticoagulation in pregnancy. I've got a fantastic biomedicine honours student who's somewhere in the audience today, and I did ask her for a photo, but she hasn't given it to me. But her name is Emily Moroney, so if you see her, she's fantastic. And she spent this year looking into the data from the registry with me in a bit more detail. We've done a review that's been accepted for publication, but what we're really interested in is that really long-term outcome data, because I think we're pretty comfortable now with what we should be telling you are the risks in pregnancy, but we don't know whether pregnancy might add to your risks down the track. And I raise that not because I think it's my job to tell you not to have a baby if indeed there is an increased risk. I think that's very much a decision for you to make with your partner, but I think it's probably part of the conversation that you want to have with your partner. I certainly think my role as a cardiologist, and if I say to people that they shouldn't get pregnant, is if I'm really concerned that they're actually going to die in pregnancy or shortly thereafter. Beyond that, the reality is that women have had pregnancies throughout the centuries with all sorts of health conditions and in all sorts of climates, you know, with famine, with war, etc. And that's not a decision for me to make. So what we're trying to look at, as I said, is whether in the longer term there are any effects from pregnancy. And there's only been a single abstract published in 2013 which looked at women many years postpartum. They reported 5 late deaths, an average of just under 13 years later, but there was no control. So they didn't include in that women who hadn't had a pregnancy. And so we don't know whether that was related to pregnancy or whether that was just what would have been seen in a cohort if we followed them for that period of time. So what we're trying to do is look at the really big picture, if you like, of women who have had a pregnancy, who have not had a pregnancy, and we're also looking at the big picture outcomes in men, because again, I think it's just nice to try and understand whether there's any difference there. And one of the things that has come out, and we just got some data last week, so I haven't got very much to show you, but in that histogram there, in the light green, is the women who have had a pregnancy, but that's the issues that they'd had, or the events per person year, prior to getting pregnant. And in the pink are women who have not had a pregnancy, so they, if you like, are the controls. And so one of the interesting things that's coming out is that it does look as though the women in our registry who have had a pregnancy may be a healthier group of women than the ones who have not. That's fantastic if it means we're getting it right, but the interesting thing is that when we looked at the data that I showed you had been published last year, the advice that women reported whether they had or had not had a pregnancy from their cardiologist was no different. So I'm not sure that we're certain that we're knowing who to pick in terms of who would be right to have a pregnancy or who would not, but maybe we are getting it right, and then let's see what happens. And then you can see, if you look at the events on the x-axis down the bottom, the emergence of little blips in dark green, and they're women who have had a pregnancy and the events that they're having subsequently. So maybe there is an increasing rate of events. The only one that's statistically significant, however, in this very early look at the data, is an increased rate of thromboembolic events. And I'm not sure why that should be, and obviously something that we'll need to think about further. I think that really demonstrates why we need to do a match study where we try and take into account the sorts of factors that we think might be relevant to women's outcomes. So, for example, the age of the Fontan, the type of Fontan, and the type of ventricle that they had, and then try and look in that matched population where the pregnancy really does seem to have an effect. So Eve has already mentioned the International Fontan Interest Group meeting that was held as part of the World Congress in Barcelona, and I was very fortunate to be able to attend that and suggest that this might be a project that we could do as an international community, because I think that's the only way that we'll get enough numbers. There was lots of interest. We're hoping to recruit from centres match data, so they'll match women that they've looked after who have and have not had a pregnancy, and hopefully that will account for any regional variation in care. And then we're going to follow them for a number of years and really look at the very big picture issues, thromboembolic events, whether we need to be sending people off for Fontan conversions or transplantation, death, and try and work out whether there's any difference or not. Ethics application is underway, and that's never a fast process, but hopefully I can stand up here in a couple of years' time and give you a little bit more information. So in conclusion, pre-pregnancy counselling is essential. I think the risks of pregnancy itself are well and consistently described, but questions remain. I think for us we need to work out how it is that we're determining risk. It appears that we might be getting it right, but there's no accepted way of assessing women pre-pregnancy. Anticoagulation in pregnancy, that's a big question. Hopefully the ProFat data will give us a bit more information. and what I like to think of as being a possible legacy effect or the long-term effect of pregnancy. So pregnancy is possible, but at minimum carries increased risk, and that seems to be particularly for the woman, if you like, during the pregnancy, but also for the baby. And lastly, can I just add my words to everyone else who's encouraged you to participate in the registry, because it's really only by having access to your real medical experience that we can try and answer some of these questions together and hopefully give you better information with which to make your own decisions down the track. Thank you.